Good afternoon, everyone, and welcome to today's webinar titled Quality Improvement in the ICU, the PEP UP Protocol 3 years later. My name is Bethany Hopkins. I'm a Medical Affairs Manager with Nestle Health Science, and I will be the moderator for today's session. Before we get started, I'd like to go over a few items so you know how to participate in today's event. First, should you require technical assistance, please dial the customer care support number shown on the screen. And if you have a moment and a pen handy, you may want to jot this number down. As you can see from the image on the right of the screen, we've taken a screenshot of an example of the attendee control panel. You should see something that looks like this on your own computer desktop in the upper right corner. The first thing I want to draw your attention to are the audio options. If you've joined the presentation listening to your computer speaker system, which is the default, and if you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will automatically be displayed. Next, it's important to know how to ask questions during the session. As a participant, your audio is on mute. However, you will have the opportunity to submit questions by typing them directly into the questions pane of the control panel. And you may send your questions in at any time during the presentation. And I will be collecting all of these questions for Heidi, and she will address them during our Q&A session at the very end of her presentation. In addition, I want to make note that there are 2 handouts for today's session. One contains the presentation slides, and the other is a certificate of attendance. And this certificate is actually available as an interactive PDF document so that you may type your name on the certificate before you print it. And lastly, I would like to note that today's session is being recorded. Now, it's my pleasure to introduce our presenter today, Heidi Nixdorf. Heidi practices as a critical care dietitian at the Trillium Health Partners Credit Valley site in Mississauga. A self-described PEP UP enthusiast, Heidi has worked closely with her ICU team to implement this novel volume-based feeding protocol as part of a quality improvement initiative in her ICU. Heidi, together with her nursing colleague, Maria Kobalecki, have presented a series of interactive learning sessions on PEP UP at the American Association of Critical Care Nurses Conference. In addition, Heidi has shared her experience at a number of international events, including 2 stints at Aspen Clinical Nutrition Week in 2014 and again this year in 2016. And she has given a number of other presentations to professional organizations, including most recently a national PEP UP webinar in the USA last week. Today, Heidi will be talking to us about quality improvement in the ICU, focusing on her experience with the PEP UP protocol. And I would like to point out that in Heidi's ICU, there were a number of other quality initiatives happening around the time when she first introduced this PEP UP concept. And instead of thinking, let's leave this nutrition quality improvement program for a better time, Heidi successfully positioned PEP UP as a bundle that would complement the other quality initiatives her unit was considering, and she'll be speaking a little more to that later on. Heidi will share how her center approached the QI process and implemented a protocol that not only improved nutrition delivery for the patients in her ICU, but truly distinguished the dietitian as a key champion for change and elevated the role of nutrition among the entire healthcare team. And I'll now turn the floor over to you, Heidi.
Wow, thank you, Bethany. That was a lovely introduction, and thank you, everyone, for joining us this afternoon. I am here today to share my ICU team's experience implementing the PEP UP protocol, which is a nurse-driven, volume-based feeding protocol designed with a few novel features that enhance the delivery of protein and energy via the enteral route. So I thought I would just throw my disclosure up there, and then we'll just quickly go over the objectives. So we'll define the PEP UP protocol. We'll identify some of the barriers to providing adequate enteral nutrition to critically ill patients, describe the benefits of volume-based feeding, explain how to successfully implement the PEP UP protocol in the ICU setting, and I'll explain a little bit how PEP UP has led to other quality improvement opportunities. All right. So I wasn't going to spend much time talking about how to use the PEP UP protocol specifically. Rather, I thought I would focus on how we went about making the decisions around the implementation of the protocol. But in case you don't know much about PEP UP or volume-based feeding, I thought I'd give you just a little bit of a summary. So I think everyone here is probably familiar with the old school rate-based feeding protocols where you pick a formula, you start, you initiate it at maybe 10, 15 mils an hour, and then you advance it by 10 mils an hour, I don't know, 24 hours until 2 weeks later you finally get to your goal rate. With volume-based feeding, the enteral nutrition prescription is written as a daily goal volume that's to be delivered within the 24-hour flow sheet day. So when the nurse comes on in the morning and sees your daily goal volume prescription, she sets that initial infusion rate by dividing the total of the goal volume by 24 because there's 24 glorious hours ahead of her. Now, the nurse can then adjust that hourly rate to accommodate for times when the tube feedings are shut off during the day for interruptions like tests or surgeries in order to ensure that 24-hour goal volume is delivered within 24 hours. And then recently we've been trying really hard to encourage our nurses to report the percentage of the tube feeding that the patient received the day before so that we all have a good sense of how adequately fed the patients are. And of course the goal of all this is to improve our delivery of enteral nutrition to our critically ill patients. Now I mentioned that there are a few novel features that are specific to the PEP UP protocol, so I thought I would just talk about those very briefly. The first one is that all patients initially receive a semi-elemental tube feeding formula. All patients start on a 100% whey modular protein, and it's 2 packets BID. All patients are given metoclopramide on day 1 of enteral feeding. But I want to reinforce the concept that the PEP UP protocol is really meant to facilitate the process of getting enteral nutrition up and running at goal within about a 24 to 48 hour period in a manner that ensures the greatest tolerance for the most patients. And as the dietitian, you reassess the formula, the protein supplement, and the motility agent daily. And if after 48 hours you feel like your patient has got great tolerance, you switch them to a polymeric formula or you take away the protein supplement if they don't need it, you discontinue the motility agent. There are 3 feeding options in the PEP UP protocol. The first one is the one that you're probably going to use most often. It's appropriate for all of those patients who are hemodynamically stable, and that's to start volume-based feeding. So on day 1, feeds start at 25 mils an hour. Doesn't matter when you roll into the ICU, that's how you start. And then beginning on day 2, the patient is automatically advanced to receive the daily goal volume. The second option is trophic feeding, and this is when enteral nutrition is delivered at a lower rate, which is 10 mils an hour, and the tube feeds do not automatically progress the next day to a daily goal volume. But I kind of want to emphasize the fact that if you start someone on trophic feeding, those are the patients that you really want to follow up on, sort of every 24 hours to reassess their eligibility to move on to volume-based feeding. And then the third option is MPO for those patients who truly have contraindications to receiving enteral nutrition. So I thought I'd talk a little bit about us, me and my ICU. We're a 19-bed medical surgical ICU with a surge capacity of 21 beds. We're a closed unit. We have 5 dedicated intensivists and 1 full-time dietitian, which is me. Now before I show you just how badly we were feeding our patients, I'd like to show you that we are really an enthusiastic bunch of people and we were trying really hard to do a good job feeding our patients. I'm fortunate that I work with a group of intensivists and a group of nurses who, they have an interest in nutrition and, they do understand the importance of providing good nutrition. So if you cast your minds way back to 2003, that was when the first edition of the Canadian Clinical Practice Guidelines came out, which informed us that having an enteral feeding protocol was a good thing. So by 2004, we had created and implemented our very first feeding protocol in the form of a physician pre-printed order, or PPO. And it was your standard old school rate-based feeding protocol. So in 2007, we thought we should audit our practice. Like I said, we're all an enthusiastic bunch. We thought we were doing a pretty good job feeding our patients. So we used the International Nutrition Survey to audit our practice. And for those of you who may not be familiar with the International Nutrition Survey, this is an international audit that was created by Dr. Darren Hyland and his research team probably around, I'm going to say about 10 years ago now. I think there's been 4 or 5 editions of it. And when you participate in the International Nutrition Survey, you receive this fabulous benchmarked performance report that really highlights your strengths and weaknesses in providing nutrition support, so both enteral and parenteral, to your ICU patients. And not only does it benchmark you against the Canadian Clinical Practice Guidelines, but it also benchmarks how well you're doing against ICU sites across the world. It can really help you illuminate the barriers you might have to providing adequate enteral nutrition to your critically ill patients. So in 2007, we used the INS, and our results were terrible, and we were really surprised. It appeared at that time that a big problem we had was our surgeons' reluctance to feed patients. So I tweaked the protocol a little bit, made it a little more surgeon-friendly. I did a huge education initiative, just to get the word out there. I talked to intensivists, to surgeons, to nurses. I probably talked to janitors. I talked to anyone who would listen to me, really. So in 2009, after we'd implemented all those changes and got the little, our little improvements up and running, 2009 we re-audited the changes we made to see if they'd made any difference. And once again, we actually did very poorly. But with the 2009 audit, it became very clear at that time that our biggest problem was holding tube feeding for many, many, many hours during the day for daily things like weaning trials, tests and procedures, and surgery. So I was kind of scratching my head wondering what to do next when, as luck would have it, Dr. Hyland's research team was recruiting underachievers like me for the PEP UP trial, which I signed up for immediately because after reviewing the PEP UP trial and the PEP UP protocol, it seemed to have exactly what I needed to overcome my barriers to providing adequate nutrition. I really wanted to be one of the first ICUs to try out this new feeding protocol, and I guess because I was so excited, I just assumed that I would be one of the, the test sites that would get the new protocol, but much to my disappointment, my ICU was randomized to being a control site, so we had to continue using our old protocol and doing a bad job for 1 more year. After the PEP UP trial was over, we had the good fortune to be invited to join the PEP UP collaborative, and by January of 2013, we had fully implemented the PEP UP protocol. And then in August of 2013, so later that same year, we participated once again in the International Nutrition Survey to see if, by implementing the PEP UP protocol, we had made any improvements at all in providing adequate nutrition to our ICU patients. And along the way, I was trying to do all those things, a good little dietitian should do. I try really hard to participate in patient rounds. I participate in our ICU resident orientation and new nurse orientation. I've done poster presentations at Nursing Skills Weeks. I was trying really hard to do a good job. So how were we doing? Our results from the 2007 and 2009 International Nutrition Surveys and the PEP UP trial showed us that on average we were only feeding our patients 55% of their prescribed energy requirements and only 52% of their prescribed protein requirements. And on average, only 63% of our vented patients were receiving their enteral feeding within that 24 to 48 hour of admission. So, we ask ourselves, why does it even matter anyway? So I'd say that the evidence for starting early enteral nutrition within the first 24 to 48 hours of ICU admission is pretty strong and well accepted. Where the confusion sometimes lies is in deciding what the optimal dose of enteral nutrition should be. And there is a significant body of evidence out there which shows us that accumulated caloric and protein debt are associated to worse outcomes. And then there's this study done by Todd Rice. This was the pilot study to the Eden trial, which shows us that there may be potential long-term benefits to providing initial full energy feeding in that first week of an ICU stay. So, from all of this, it looks like we should be trying to get tube feeding started early and up and running as close to goal as possible, as soon as possible. But then we come to the guidelines, and this is where things can get a little bit tricky. So, again, as luck would have it, as it seemed like it was just very shortly after I had the PEP UP protocol implemented and up and running smoothly, then the surviving sepsis guidelines were published. And as you are probably aware, the surviving sepsis guidelines suggest to avoid mandatory full caloric feeding and use low-dose enteral feeding in the first week of a patient's ICU stay. So after having 3 or 4 small heart attacks, I sat down with a few of my intensivists, and we reviewed the 3 randomized controlled trials that the surviving sepsis guidelines are largely based on. These studies found that there is no effect on mortality with the provision of trophic feeding in the first week. But when we took a closer look at the patient populations that are included in those trials, we really felt that they did not strongly reflect our patient population. So we actually have a lot of septic patients. Most of them have pneumonia. Our ICU stays are a lot longer, usually about 10 to 12 days. And our patients are older. They tend to have higher Apache scores. They have a lot more malnutrition and tend to be a lot skinnier. So I had a big sigh of relief, and we carried on with the PEP UP protocol. Now, both sets of the North American practice guidelines have been updated in the last 2 years. The Canadian guidelines were updated last year, and of course we're all familiar with the American guidelines, which are just hot off the press early this year. And I'd say generally that both of these guidelines recommend starting feeds early and then trying to achieve targets for your caloric and protein goals fairly quickly after initiating your enteral nutrition. But then you come to a guideline. It's the third one down there. So in reference to the guideline about using trophic or full feeding for patients with ARDS, something that I'd like to point out that I've kind of discovered since these were published is that if you are using the Nutrix score, if you are using the NRS 2002 score to determine nutrition risk, most patients with ARDS are going to score as a high nutrition risk. And we also know that the 2016 guidelines recommend that you try to provide these types of high-risk patients with greater than 80% of their goal nutrition. So it sort of does take the question mark out of that recommendation, whether to go trophic or whether to go full feeding. So while we were working through the PEP UP process, we went looking through the literature for a realistic feeding goal that had some potential clinical outcome benefits, because we knew that trying to achieve 100% feeding adequacy in all of our patients was probably unrealistic. So we used this study by Dr. Hyland to help us determine what a realistic feeding goal should look like. So this was a prospective multi-institutional audit that included 352 ICUs from 33 countries, almost 8,000 mechanically ventilated patients who remained in the ICU for at least 96 hours, and then the data was adjusted for all those fabulous evaluable days and covariates. And the outcome was a 60-day mortality benefit when the patients received about 80 to 85% of their goal protein and calories in the first 12 days of their ICU admission. So we felt that this was strong enough evidence to use as our quality target, but considering we were only feeding our patients about 50% of their requirements, this meant that we were doing a lousy job. And I just wanted to point out that our decision to use a goal of 80 to 85% was recently supported not only by the brand new 2016 Aspen SCCM guidelines, but also by this study by Nicola, which came out around the same time as the guidelines, where they found that by achieving greater than or equal to 80% of the prescribed protein was associated to reduced mortality. And even before the 2016 guidelines were published, it was becoming clear to us that there definitely are some patients who might benefit more from, maybe let's call it aggressive nutritional therapy, than others. So a couple of years ago, I started using the Nutrix score. And a lot of people often roll their eyeballs when I say that, because the Nutrix score was initially validated using interleukin-6, which we all know is not a readily available measurement in our everyday ICU lives. But it turns out that interleukin-6 contributes very little to the score and can actually be excluded. So subsequently, the Nutrix score has been revised, and this revised version was validated, and that's been published in Clinical Nutrition. That was published, I think, last year. So the Nutrix score has really helped me to focus my efforts on that subgroup of patients which appear to benefit the most from optimizing the delivery of enteral nutrition in the first 12 days of their ICU stay. From the International Nutrition Survey, we learned that our most significant barrier to providing adequate enteral nutrition was the inability to make up for that lost volume of enteral nutrition when things were held for things like daily weaning trials and bedside procedures. But it wasn't our only problem. The enteral preprinted order was a separate document from the ICU admission preprinted order. So I guess I'm a little bit ashamed to say that we're still a paper-based institution. We don't have an electronic medical record as of yet. So we're still printing off admission orders and all those types of things. So, you know, in the chaos of admitting a new patient to the ICU who's, you know, crashing and the unit clerk's trying to get that ICU admission order printed off, the enteral pre-printed order would often get missed. So since then, we've actually linked those two documents so that they print out together. And then, of course, the surgeon's reluctance to feed early, I think, will be a monkey on my back for as long as I work as a critical care dietitian. So why did I choose PEP UP? The main reason why I chose PEP UP was because the PEP UP protocol had exactly what I needed to overcome my biggest barrier to providing adequate enteral nutrition, and that was a nurse-driven mechanism for catching up when enteral nutrition is held. But PEP UP also comes with other great tools and guidelines that help direct nurses through important decision-making around issues like managing gastric residuals or managing diarrhea. And it's all to prevent the often random and mostly unnecessary stoppage of tube feeding. Another huge reason why I joined, or why I chose PEP UP, was because I did have the invitation to join the PEP UP Collaborative. And the PEP UP Collaborative was created and formed by Dr. Hyland, and at the time, Rupinder Dhaliwal, a research dietitian who was working with him at the time, they formed the collaborative. It was designed to really foster a network of clinicians like you and me who are dedicated and committed to optimizing the delivery of enteral nutrition in the ICU. And the goal of the collaborative was to provide clinicians like you and me with all of the practical tools and strategies and, you know, resources that we needed to improve the delivery of enteral nutrition. So they gave me this fabulous toolbox full of things like templates and posters and pocket cards, PowerPoint presentations. There's a computer-based self-directed learning module for nurses. All of these things were handed to me. I didn't have to create them myself, but I could modify them to suit my ICU. So it took a lot of, you know, the weight off my shoulders and trying to think up all of these things that I may need, you know, to use to implement a protocol like this. Of course, in exchange for all of this support, it was mandatory for my ICU to participate in the 2013 International Nutrition Survey to audit whether implementing the PEP UP protocol with all of this support actually had made a difference. But I wanted to share the great news with all of you in that the PEP UP tools are now available to everyone. So you don't have to be a collaborative member to access these tools. So I urge you to go on to the criticalcarenutrition.com website, go into the PEP UP side of the website and start checking things out. And I've just included a very small handful of some of the tools that are available just to show you really quickly. This would be the template that you would use to help you structure your order set or pre-printed order, whatever you call it in your facility, in a way that, in sort of the PEP UP design. This is the volume-based feeding schedule, which the nurses use to adjust the infusion rate of the enteral nutrition during the day if the feeds are held for any reason. This is the gastric feeding flow chart, and this was actually a really important tool for us because prior to PEP UP, we didn't really have a great standardized way of managing residuals, and it seems like each of our intensivists kind of had their own idea of what to do. So this really helped us to standardize things, and I know it's probably a little bit squinty and hard to read, but if you take a look at the green box on the right-hand side, you can see that it directs the nurses through a series of strategies to manage gastric residual volumes instead of that knee-jerk reaction of just turning the feeds off. You can see at the top here too, again, if you're like me and you need to squint your eyeballs up, your institution can decide what you're comfortable with in terms of setting a gastric residual volume cutoff. So you may pick 250, you may pick 500, you may be a facility that doesn't even measure gastric residual volumes at all. These are the PEP UP pocket guides. There's a fantastic 11-minute nurse education video. It's concise. It gives you a case example using the PEP UP protocol. And this kind of quick and very directed type of education is super important when you're trying to provide education to nurses who are extremely busy during the day. If you haven't heard about nibbles, these quickly became one of my favorite things. NIBBLE stands for Nutrition Information Bite, and these are one-page articles that they summarize the literature on all the hot topics in critical care nutrition. And I would say that they really help you, as the dietitian, to provide consistent and credible information to your physicians and nurses. So it really helps you to stand out as the expert in critical care nutrition in the ICU. And then this little gem of an article, which was just published, I believe it was February's Nutrition in Clinical Practice. I really wish this had been around when I was going through the process of implementing PEP UP. What it is a review of the supporting evidence and a review of some of the controversies associated with each component of the PEP UP protocol. So it really helps you to, when you're having conversations with your nurses and physicians, it's a quick reference guide so that when your physician says, why would we provide motility agents right away, you can flip to this review article and you can get to the references to support that component of the PEP UP protocol, and you can have a good conversation. I mentioned that we were a control site that participated in the PEP UP trial. And of course, the main outcome of the PEP UP trial was to assess whether or not the PEP UP protocol improved adequacy of feeding. But a big part of the study included a survey of the nurses' perception of the protocol. And this is super important because the nurses are the ones who are using the protocol and all of the tools that go with it. And when I surveyed our nurses after we had implemented the protocol, they reported that it's very easy to use, and most importantly, it didn't increase their workload at all. So of course, whenever you're trying to make any kind of changes or implement anything new, there's all sorts of challenges. And I'll be honest with you, probably the worst part of the whole process for me was trying to get the darn thing through the administrative approval process. So, going through the 9-month odyssey of trying to find the right committees, the right managers, the right signatures, it really tested my patience and my enthusiasm. But once that was done, selecting the most appropriate educational opportunities for our nursing staff became, the next thing on our agenda. And that's when, I urge you to go out there and make friends with and get to know your nurse educators, because they really can help you to understand the most effective and the most efficient ways of providing the education to your ICU nurses. It's what they do for a living. So I was so fortunate that Maria, who is the nurse educator in our ICU, she quickly became probably my biggest nutrition champion. I have to say that her endorsement of the protocol really helped the other nurses to buy into it. And I have to say now they truly own it. But her and I sat down and we sorted through that toolbox of resources that I had received from the PEP UP Collaborative. And we chose, a bunch of them. We used the pocket guides. We tried using the self-directed learning module. But when we surveyed the nurses after everything was kind of said and done, the two things that stood out as being the most effective for our nurses were the bullet-style in-services and then the one-on-one follow-up I did at the bedside with the nurses. So the bullet-style in-servicing took about 2 weeks. I did the day shift, Maria did the night shift, and about 2 weeks we had covered most of the nurses. And we used the PEP UP PowerPoint presentation that was already created and available on the criticalcarenutrition.com website. So I urge you to check that out. And then, as I mentioned, I followed up after the in-servicing just to check in with the nurses at the bedside to see how things were going, see how they liked the tools, if they had any questions, any concerns. And I used another resource called Information for Nurses, which again was available as a pre-made resource for me to use. I didn't have to invent it myself. When I've talked to other sites about their challenges in the process of implementing PEP UP, they're fairly similar. So there's time-consuming local approval processes, choosing the right continuing education efforts for nursing staff. Changing the ICU culture is a tricky one because, if you work with a group of intensivists who aren't willing to look much further than the surviving sepsis guidelines, then it's probably going to be a little bit of an uphill battle. But I do believe that, with a little bit of persistence and a positive attitude and maybe some gentle nudging, using things like, solid information and evidence, using those nibbles, you can start changing the way that others value nutrition in the ICU. And I do believe, I think I see this happening with a few of our surgeons. Some sites report concern regarding the use of motility agents. There's concern regarding patients at risk of refeeding syndrome. And then some ICU sites have had some difficulty incorporating it into their electronic medical record. The feedback that I've received from our nurses is that they feel empowered. So they feel like they have the tools now to guide them through tube feeding decisions, and they don't have to call the doctor at 11 at night, and they don't feel like they have to wait for me to roll in the next day. And both the nurses and I noticed that there's a greater collaboration between me and the nurses. So because the nurses have more ownership in the process, they're far more interested in it and they want to talk about it more. So I'm having far more problem-solving discussions versus, well, I just shut the feeds off and went for lunch. So now that we have the protocol implemented, it does become very important to ensure that the nurses and the physicians are compliant with the protocol and all the tools. And this is easily done with routine daily follow-up, because what do you do when you follow up with a patient? You check to see if they were adequately fed the 24 hours prior to. And so when you're checking out the flow sheets, you're going to see fairly quickly if the patient went for a test, or if they had a spontaneous breathing trial. If the feeds were held for any reason, you're going to see quite clearly if they were adjusted appropriately or not. And I have to say that most of the times when I find that there's been a problem, when I've followed up with the individual, it's usually, it's an agency nurse, or it's a new nurse, or someone who's just working casual. And I usually can address these little things on an individual basis. There are times when we have a new ICU resident and they just don't know how to fill out the pre-printed order. Like I mentioned earlier, I participate in ICU resident and new nurse orientation, so I do try to get the information about PEP UP out there early. I send out monthly PEP UP pointers, so this is my subliminal PEP UP brainwashing program. So they're just monthly emails that are super repetitive, that just go over very quickly the main points of the PEP UP protocol so that, I can embed all of it into our nurses' brains. And then just recently, in February, we did something fun called the PEP UP Challenge. And so I sent out, for each week of February, I sent out a multiple choice question, and the first nurse to get back to me with the correct answer won, a $5 coffee card. So I have to, really, I have a lot of respect for our nurse managers because she really supports me and the other allied health in some of these initiatives that keep our nurses engaged and motivated. I give a lot of positive feedback when things are done right because I feel like in this world everyone likes to tell you often what you're doing wrong. So I do go out of my way to point out when things are done right. And to give you an example, last fall I had a patient who went for CT in the morning. He self-extubated in the afternoon and in the meantime pulled out a couple of feeding tubes. And that nurse was still able to give that patient almost 100% of his prescribed enteral nutrition. So in rounds the next day, I made sure that the team understood what a great job she'd done. I still work on encouraging surgeons to feed sooner. And then I audit my practice using the bedside monitoring tool, and I believe next year is the next edition of the International Nutrition Survey. So we'll definitely participate in that again to make sure that we're staying on top of things. So in mentioning the bedside monitoring tool, I thought I would show you this because after I was given access to this through the PEP UP Collaborative, it quickly became another one of my new favorite things. And like all the other resources that have to do with PEP UP, this is now available to everyone, and you can access it on the Critical Care Nutrition website. I have to say that for the first couple of patients, it's a little bit tricky, but once you get the hang of it, it's a powerful tool that visually demonstrates how well or not well you're feeding your patients. So again, you're going to have to squint your eyeballs up and maybe move close to the screen. But along the x-axis here, you have the number of days that the patient is in the ICU. Along the y-axis, you have the nutrition adequacy, and in this case, it's for calories. So how well you're feeding your patient. You have the red line. The first red line is your 80% mark, green line's 100%, and then when you get to the second red line up here, you're 120%. That's a little bit of overfeeding. So if you take a look at this patient, he was in our ICU for about 15 days. We got feed started. He had a GI bleed. We got them started. Things were going well. He had a GI bleed. He was on propofol, so you do notice there's a little bit of overfeeding going on. But ultimately, if you take a look at this bar along the side, I look at this as a gas tank. And when the gas tank is mostly blue with very little red, you know you've done a good job. And I can't read this, but I think this patient came close to receiving 90%, I believe, of his prescribed calories in the 15 days of admission. The other wonderful thing about the bedside monitoring tool is that it calculates the Nutrix score for you. So it'll prompt you to collect specific types of information from the patient chart. It has a built-in Apache calculator. It calculates the SOFA score for you, and it will do the comorbidity index for you. So, all you need to do is follow the prompts, and in the end, it calculates the Nutrix score. So you don't have to do any kind of mental gymnastics. And you can see here that a similar graph is available for protein. So you get the same kind of information for protein. I want to reassure everyone that PEP UP does not replace the RD. There's absolutely no loss of status for the dietitian. This is a tool that supports the optimal delivery of a very important therapy that significantly impacts patient survival, and I truly believe it supports the collaboration between the nurse and the dietitian. I really think that by implementing the PEP UP protocol in our ICU, it's actually raised the profile of the dietitian, which is fabulous. And it's also raised the profile of enteral nutrition therapy as a significant and essential part of the medical management for our critically ill patients. So I'm so proud to tell you how we're doing now. After we implemented our PEP UP protocol and we re-audited ourselves using the 2013 INS, our patients are now receiving 83% of their 83% of their caloric requirements. 78% of their protein requirements. So we still have a little bit of work to do there to get that nudged up above the 80% mark. And 90% of our ventilated patients are receiving enteral feeding within 24 to 48 hours of admission. And from the results of the 2013 International Nutrition Survey, you can actually see that the PEP UP sites consistently delivered more protein and calories than the non-PEP UP sites. And if you are familiar with the International Nutrition Survey, you'll know that the top 10 performing ICUs are eligible to win a Best of the Best award. And so I'm proud to say that in 2013 we finally qualified to win a Best of the Best award, so that was fantastic. And then in 2014 I became the first dietitian to win the Trillium Health Partners Allied Health Professional of the Year award for the PEP UP Quality Improvement Initiative. So I guess I have to say that PEP UP really changed my life. And then I also wanted to highlight some interesting projects that have evolved from implementing the PEP UP protocol. The first one being PEP UP and the high protein formula trial. So if you think back to a couple of slides ago when I showed you that although we had significantly improved our delivery of calories and protein with PEP UP, we were still below that 80% target for protein. So we were invited to participate in the high protein formula trial to see if by using a very high protein formula in combination with the PEP UP protocol improved our delivery of protein. You know, as we all know, one of the big drawbacks of using modular protein supplements is that they're often forgotten or not given for any number of reasons. So by combining a very high protein formula with a protocol that ensures the adequate delivery of enteral formula, we figured we could improve the delivery of protein to our patients. And I just thought I'd throw just an example of one of my most recent hardest to feed patients. This is Mr. F, who, you know, he's a peritoneal dialysis patient on propofol. He was septic, he was fluid restricted, getting lots of calories from lipid, but also calories from dextrose. And you can see from the bedside monitoring tool graph that, you know, he was woefully underfed in protein. And the results of that trial showed that, you know, we were successful. We were able to significantly improve our protein delivery, and especially for patients like Mr. F, who are, you know, extremely challenging. So other types of patients that seem to benefit are obese patients, patients on CVVHD, patients receiving propofol, and you know, we've all had patients where this is one and the same person. And of course, patients like Mr. F who are getting calories from dextrose. PEP UP also led the way to two other interdisciplinary initiatives, and you know, Bethany mentioned this in her introduction. So Wake Up was our initiative to prevent or minimize the occurrence of ICU delirium, and Step Up was our early mobilization initiative to help get our patients moving as soon as possible. So we PEP UP, Step Up, and Wake Up people, and they all seem to fit together very nicely. Most recently, you know, now that we're providing, or we're able to provide consistent, adequate nutrition using PEP UP, and we're providing consistent early mobilization using Step Up, our intensivists are now very curious to know whether, you know, the combination of the two have any impact on our patients' lean body mass. So they've been very supportive, and they've been encouraging myself and our ICU physiotherapist to start exploring some of these, you know, new things like using ultrasound to measure lean body mass. So, you know, we're not there yet, but it's something exciting to look forward to in the future. So I do encourage you to think about introducing PEP UP to your ICU, but you really need to audit your practice and establish your goals. You need to figure out if there's actually a need or an interest to improve the feeding practices in your ICU. You may audit your practice and you may already be a superstar, so you don't need to change a thing. But you know, you can use tools like the International Nutrition Survey or the Barriers Questionnaire to help you to identify your specific barriers to optimal feeding if you're not quite a superstar yet. you really need to identify your nutrition champions. So whether they're nurses, doctors, dietitians, respiratory therapists, physios, I really believe it takes a village to feed a patient. And then tailoring your education and communication to the people who are receiving it is super important. So choosing the right tools, choosing the right resources. And as I mentioned before, a lot of these things are available to you already. They're ready to go. You tweak them to suit your institution, and you don't have to do any additional work. And then, of course, ongoing monitoring and feedback is important to make sure that you stay on track with everything. And don't be afraid to reach out for support. When you embark on a project like this, you have lots of days where it seems like you take one step forward and about 100 steps back. But there are lots of people out there are ready to help you and support you, and we all want to see you be successful. So Margot Lemieux is the nutrition project leader at the Clinical Evaluation Research Unit in Kingston. She works with Dr. Hyland, and she really is the primary contact for any kind of questions, especially regarding the tools and the resources that are specific to PEP UP. So she's really a great resource if you have questions of that kind of nature. And then Dr. Darren Hyland, he's just so generous with his knowledge and his time. And if you have any questions, especially regarding the research behind the PEP UP protocol or the components of the PEP UP protocol, he encourages you to send him an email and talk with him, because he's very enthusiastic in helping clinicians like us out. And then there's always me. So I've gone through the process. You can use my ridiculously long email address to, contact me. And for little things, I may be able to help you out. So I'm always there for you. Most importantly, be positive and don't get discouraged. It is a big job, but if you keep focused, little by little, you'll get the job done. So to summarize, audit your practice, establish your goals, identify your barriers and explore your options. And maybe PEP UP has what you need. Identify your champions, educate and communicate, and monitor and follow up. All right, so that ends my presentation. I'll turn it over to you, Bethany, now, and we'll do some questions and answers.
Wonderful. Well, thank you, Heidi. And I found your presentation just to be a great inspiration, and I really loved all of the practical information and that you provided along the way, so thank you. So I will be taking questions from the audience, and I'm organizing them. So if anyone has any questions as we go over the next 10 minutes, please feel free to continue to submit. So Heidi, we have a question here, and it's, do you initiate volume-based feeding on patients at risk of or showing evidence of refeeding syndrome?
Yeah, that's a good question. So for patients where, they already have evidence of, or for example, we have two well-known anorexic patients who are in our catchment area, and when you have someone who is a true high risk, you have that trophic feeding option. So it's a good option to start at. You start at the 10, you keep monitoring their electrolytes, and as soon as their electrolytes start to stabilize, then you think about moving to volume-based feeding. But a little trick that I've done that worked well was that we had a patient, it was one of our anorexics, and we had her on trophic feeding probably for the first 3 or 4 days. Then we moved her to day 1 of volume-based feeding. So if you recall, day 1 is actually 25 mils an hour. And then after we were satisfied that she tolerated the 25 mils an hour, then we went to the daily goal volume.
Great, thank you. We have another question here around GRVs. So with the new the U.S. critical care guidelines, there is a hesitation perhaps to use gastric residual volumes. And are you still monitoring gastric residual volumes, Heidi, in your unit?
We are. So we, all my intensivists are aware of the recommendations. They're aware of the literature, and there is a bit of a reluctance at this time to change that practice. but it's something that we're going to talk about in the future. I want to point out too, actually, that something that's interesting that came up in, from changing from our old protocol to the PEP UP protocol, using the International Nutrition Survey, our incidence of significant gastric residual volumes was 10% using our old protocol, and it went right down to 1% using the PEP UP protocol. So having sort of a standardized way to measure gastric residual volumes and consistent way really helped us out. So,
okay, thank you. Another question is wondering around the feeding rate. So how do the nurses know when to adjust the feeding rate, and is there a formula tracking form that they use?
Yeah, that that volume-based feeding schedule I showed as part of the tools that are available. I would urge the person who asked that question to go to the website and check out that tool, because all of that information is right on that tool, and it guides the nurse through the calculation and how to use the chart in order to get to the new infusion rate that will be required.
Okay, thank you. And I'll just mention as well that there are hard copies of the volume-based feeding initiation chart that are available, and they can be put into a nursing cardex or binder, or also mounted on the wall. And if anyone is looking for hard copies of these or a cardstock type of resource, you can also contact your Nestle Health Science representative, and they'll be able to give you some copies of that resource if that's helpful. But it is available electronically, as Heidi mentioned, on the Critical Care website. So another question, Heidi, is around glucose control. Were there any challenges or concerns with patients' glucose control with this volume-based feeding protocol?
Originally our intensivist, that was something that we were concerned about, and so again, using the International Nutrition Survey, a large component of that survey actually deals with glycemic control. So when we compared our glycemic control using our old protocol to our, using the PEP UP protocol, the only thing that changed was the protocol. We do have like an insulin nomogram that we use, so an insulin infusion, and that didn't change. So it's been the same between protocols. That being said, we had no change in our rates of hypoglycemia, no change in the rates of hyperglycemia. The only thing that changed was that now we're using a few more units of insulin because we're feeding our patients more nutrition.
Thank you. A question here around pressors. So how do you transition patients on stable or decreasing doses of pressors over to volume-based feeding?
Yeah, that's a good question. So you always, again, you have the option for patients on inotropes. I think right on the protocol itself, it encourages you to use the trophic feeding option for most patients on pressors. And when you're satisfied that they're hemodynamically stable, so, and that can mean different things depending on which ICU you're in and what, how your intensivists feel about things. So when our patients are hemodynamically stable, I'll go straight from the trophic feeding right to daily goal volume the next day if we're satisfied that there's good hemodynamic stability. But another option, and something that I've done similar to that anorexic example I've given you, is that we've started a trophic, and then just to be on the cautious side, the next day I started on day 1 of volume-based feeding, which is about 25 mils an hour, and then day 2 we progress, or the next day we progress to volume-based feeding. So hope that helps.
Okay, thank you. Another question is around the use of motility agents, and you talked about that earlier, I know, in your presentation, but was there any pushback from intensivists or other healthcare practitioners around the use of motility agents with certain patients with the volume-based feeding protocol?
There actually wasn't. I was really surprised about that. And you know, again, I had some of the evidence. I had the articles. We reviewed all of the, you know, the evidence that is available, and that's where, you know, again, I encourage you to get the Lee review article that was just recently published in Nutrition and Clinical Practice, because it gives you a really good summary of the evidence for those motility agents. But surprisingly enough, I thought that I was going to get challenged on that, and you know, I wasn't. So I guess I just got lucky.
Okay. You've talked about a number of different, you know, potential enablers, barriers. Is there one thing for your site, Heidi, that stands out to you as a real key that, you know, enabled you to have success with this PEP UP protocol? Is there one particular gem or nugget you'd recommend for people?
I think probably for me, you know, I mentioned earlier that the the worst part of it for me was trying to get through all the committees. And, you know, probably for me the biggest thing that helped me out was having previously sat on some committees and built up some relationships with the people who, you know, when PEP UP came along, I needed their signature. So if you're able to, you know, if you're able to go out and join, you know, I know we're all pressed for time, but you're able to participate in other kinds of committees, other kinds of situations where you're exposed to management or people who have signing authority, I encourage it, because then you build trust and a relationship. And, you know, I think maybe if I hadn't have had that, my 9-month process of trying to get signatures and find committees could have been a lot longer. So I don't know if that's very helpful, but that's something that I think really helped me.
Mm-hmm. I think that's a great tip. So just, you had a normal gestation.
Yes,
relationship.
I could have had a baby in that time.
Yeah. Oh, okay. Well, that actually concludes our questions, and we're just doing really well for time. And I don't know if there's any last questions from the audience. I know Heidi would be interested in hearing from anyone out there, you know, that is using volume-based feeding, you know, and what their experience has been. And she's provided her contact information very kindly as well. So any last words before we close, Heidi?
Nope, I think I've said all I can say.
Yeah. Well, look, I thank you so much for a very engaging presentation. And I want to thank everyone as well who joined us today in this quality improvement in the ICU, the PEP UP protocol 3 years later. And once you leave the webinar today, you will receive a very short 4-question survey, and we would greatly appreciate if you complete this and provide your feedback. And you will also receive a follow-up email within the next few days that will contain a link if you'd like to go back and watch the recorded version of today's webinar or share it with other colleagues at your site. So on behalf of Nestle Health Science and our presenter, Heidi Nixdorf, thank you for joining us today, and have a great rest of your afternoon. Bye for now.